clear to you, and then we'll have time towards the end for discussion and more questions. Okay. So just a little bit about me. My degree is in economics and public policy from the University of Michigan, and I spent the first part of my career at the School of Public Health on faculty there. And so that's kind of when I made a big transition towards health economics from kind of economics more generally. And kind of my training is really kind of as a statistician and as an applied statistician. So thinking about having very rigorous training in statistics and then trying to apply that in the real world where the data and the situation don't necessarily, they're kind of not textbook, but kind of being more creative and thinking about how to use and leverage statistical analyses in order to kind of understand what's going on in the real world. I've taught at the graduate level for many years, microeconomics, statistics, research methodology, and health economics. And I've been working with South African data for 20 years. So I'm coming up on my 20-year anniversary of working kind of with South African colleagues with South African data and spending time in South Africa, which is one of my favorite places to be. And I started about 12 or 13 years ago incorporating clinical shadowing into kind of my approach to research. And so Prof Mendelsohn invited me many years ago to kind of come in and shadow the team. So I've shadowed the team here many times over the past 15 years or so, 12 to 15 years. And my research started off focusing on unemployment and shifted towards working on HIV, then tuberculosis. And I've done a lot of work on COVID-19 since the pandemic hit, primarily in the US, but a little bit in South Africa as well. So just some old photos from 2014. That's Sean Wasserman working with kind of doing the clinical shadowing, and Dr. Nikki Kumalo at the Guguletu Day Clinic back in 2014 as well. And so my approach to my research agenda is that we have kind of available data. We need to use statistical and kind of inference methods to kind of get evidence from the data that's available, and then use that to inform kind of practice and policy guidance. Oftentimes, we really don't have kind of good quality data, and so I need to build a kind of a bridge between the data we have and the answers we need, and that's going to be using kind of a combination of statistical methods, thinking about mathematical models, and then real world insights. I'm often using kind of multiple methods combined to try to kind of learn what we can from the available data when we don't have high quality data like RCT results or something like that. So the outline for today is I'm going to be talking about spillovers, also known as externalities, also known as interference and indirect effects. So we'll talk about kind of what are these spillovers and why do they cause problems in RCTs. We'll talk about how we can address these problems with clinical trial design. I'll talk a little bit about a kind of a study that uses best practices, and then I'll get into a little bit of discussion about examples of spillovers in my work. Because a lot of my research has been focused on kind of how do we identify spillovers and measure spillovers and use that to kind of come up with new and potentially creative policy ideas. Okay, so spillover is a pretty universal phenomenon. Every field has multiple names for it. So in economics, we call them externalities or spillovers, and I'll use the term spillovers throughout this talk, but it's kind of the same thing. Interference in statistics, stable unit treatment value assumption or SUTVA. It could be a violation of individualistic treatment response, and in medicine, we talk about indirect effects, contagion. Sometimes it's grouped within kind of ecological effects or secondhand treatment exposure. But hopefully one of these words here will sound somewhat familiar to you, but we'll get into kind of what the topic is. But all of these things are referring to the same concept. Okay, so the concept of spillovers is really a core concept in economic theory. And the way that we think about it in economic theory kind of informs a lot of kind of policy and a lot of kind of the rest of the field. So the idea about a spillover is when we have kind of two parties that are making a decision together, making an exchange. So we often think about that as kind of a buyer or seller in a market, but we can also think about it as like a clinician and their patient making that decision, or just kind of two individuals making a decision, or one hospital and another hospital making a decision. And the idea is that decision is made, and the results of that decision influence other people, either kind of with positive benefits or negative costs. but those other people had no influence on that initial exchange. So you can imagine having a conversation with the patient, deciding what's best for the particular patient, but you're not necessarily considering kind of who else is in there, always who else is in their household. That the patient's not considering everyone else in their household or everyone else in their community when they're making their decision about kind of what's best for them. And so we think about these people who are kind of influenced but don't have an influence as external actors. And it's not saying that they should have influence over that decision. It's just saying that they are kind of, they're going to be affected by it. And so it's really important that we think about this as kind of a technical concept that has to fulfill these particular conditions, because it's not just any unintended consequence or just any indirect effect, because there could be a consequence the patient didn't think about and then something happened in the future that didn't work out very well. It's not about that. It's about these external actors that can be expected to be influenced, but don't have any say. And so here are some examples. When we think about herd immunity from vaccination. So that's a positive spillover. So we say a positive spillover if it's a benefit. And so somebody decides whether to get vaccinated, making a decision with their healthcare, their healthcare provider. And then based on that decision, it's going to provide or not provide indirect protection to people around them. And those people are not kind of sitting at the table having the conversation about whether that person is getting vaccinated or not. And even if someone's getting vaccinated thinking, oh, okay, well, I want to get vaccinated to protect myself, but also to protect my community, they're still not fully taking into account everybody else's preferences. And so they're still, even if they're thinking about other people and thinking about being altruistic, it's still not capturing the kind of full, those kind of full indirect effects. Also, I know this team has done a ton of groundbreaking work on antimicrobial resistance. So again, that's thinking about this negative spillover. If we're using antibiotics excessively and in ways that we shouldn't be doing, that's going to kind of increase the spread of resistance, add this extra cost, and that is going to be borne, in fact, often by the patient themselves in the future, but also by other people as well. So we have an example of a negative spillover where these external actors are going to have kind of increased costs, kind of negative impacts on them. And then we think about in the case of smoking, when someone's thinking about smoking, they're not always fully considering the impact of secondhand smoke on people in their household, people in their community. And again, people often somewhat consider that, but they wouldn't kind of fully take those into account. And that's where we have this kind of this friction, this disconnect. Um, and the kind of key insight from economics is that when we have either positive or negative spillovers, we're going to have a situation where we're not at the kind of optimal outcome. If we took the big picture view and decided, how much smoking should there be in the world, how much vaccination should there be, kind of a big picture benevolent social planner would say, well, we want more vaccination because we want more of this herd immunity and more of this indirect protection, that we would ideally have more than we do if we just let everybody make their own individualistic decisions. And so from an economics perspective, anytime we have spillovers, either positive or negative, it means that we are going to end up stuck in kind of a suboptimal outcome with either not enough of that exchange, that vaccination, for example, or too little, sorry, or too much, for example, of smoking, compared to what would be optimal if we took that big picture view that took all of these external actors' benefits and costs into account as well and made the decision was best for everyone. So whenever we have spillovers, what that does is that kind of motivates the need for some kind of, I say, higher level authority. Oftentimes that's going to be government policy, but it could be practice guidelines, basically saying we know if we left individuals to make this decision by themselves, then we would end up at the suboptimal outcome. So we're going to add in some clearer guidelines or some additional subsidies or some more encouragement to try to get us to this kind of more optimal outcome. And what that looks like is, for example, with vaccination, often subsidizing the cost. So saying we want to kind of encourage more vaccination, we'll make it free. in the US. I know other countries have it's already included things in like national health insurance and things like that. And then when there's something like a negative spillover with smoking, then there's policies that say these are no smoking zones that are going to prevent kind of that secondhand smoke negative externality. Because if we just kind of leave the system to its own devices, we're going to get at that suboptimal outcome with not enough vaccination and too many people smoking. Okay. So let's think a little bit about kind of so spillovers exist in the real world. They exist in health. They exist once you start seeing spillovers, you see them everywhere. You see them in your household and in your communities. Um, but like, how do they kind of manifest specifically in clinical trials? So clinical trials, whenever you have a situation where and in this case, I'm going to talk about a treatment, but we can think about the treatment as being kind of a trial more generally about any kind of intervention that we are providing. I kind of it could be in health, could be in any other field, but the standard RCT design where we're kind of comparing the treatment group and randomizing and then comparing the treatment group to the control group, that relies on this assumption that the patient's outcomes and compliance depend only on the treatment that they are randomized to receive. So that is only an unbiased estimate of this treatment effect, the effect of the treatment, um, if there are no spillovers. And so as soon as there are any spillovers, that's going to be introducing bias. And the fact is that most treatments do have some spillovers or some kind of indirect effect, but oftentimes it's kind of small enough that we kind of generally ignore it. But of course, with infectious disease, those spillovers are often quite substantial, and so we can't ignore it. Um, and so the spillover could be when the treatment affects the outcomes of another group. So we can think about kind of indirect protection from vaccines for the control group. It's kind of our kind of a very common example. Or it could affect the compliance. If you think, well, everybody else is going to get this vaccination, then maybe I don't need to get vaccinated because, to go along with my treatment assignment because everyone else is going to get vaccinated and that's going to be enough protection for me. So again, it can affect either the outcomes or the compliance. Either way, it's going to potentially introduce or will introduce some kind of bias into the RCT. And again, we think about this as somebody who is not the primary target. So that's another way of saying kind of these external actors. So if the target, for example, is a household and you're treating the whole household by vaccinating one person within it, then in that case, the whole household is considered part of that target. That we are kind of intentionally treating them, but treating them with one vaccinated person within the household. But if you're treating by the person and it's their next door neighbors, then that would be considered not the primary target. Okay. And so we often use this word kind of contaminate. So the spillovers are going to contaminate the control group. And the way we can also think about this is that the control group is kind of getting partially treated. If we're trying to assess the kind of the protection benefits of vaccination, then we only treat the treatment group, they get vaccinated, and the control group doesn't get vaccinated. If they're interacting, then the control group is going to be benefiting from this indirect protection. And so they are actually getting some kind of dose of the treatment themselves. And so again, we're not getting a kind of pure control group estimate. And we'll talk a little bit in a few minutes about kind of how we can address that. And so kind of thinking about this partially treated. So it's kind of a good intuition when you're kind of looking at a study that didn't fully address the spillover issue and you're trying to think, well, how do I interpret where is the bias showing up? Then we think about the spillovers as being partially treated. And that can be kind of a partially treated with a benefit or partially treated with some kind of negative outcome. And so the key part of spillovers is that it's going to lead to either overstating or understating the effect of the treatment, depending on whether the effect is kind of positive or negative. So if the treatment creates a positive spillover, so positive spillovers are benefits. So the treated group creates a positive benefit to the control group. So again, our control group is going to be partially treated. If we're just comparing those two, kind of assuming that one is 100, close to 100% treated and one is not treated, then we're going to be understating the overall benefits because instead of comparing kind of pure treatment to pure control, we're comparing pure treated to partially treated. So we're going to understate the positive benefits if there's a positive spillover. And if the treatment creates some kind of negative spillover, then we'll end up overstating the effect because the control group will be kind of negatively impacted by the spillover. They're going to look worse than they would otherwise, and it's going to look like there's a bigger treatment effect. Okay, and so I've put this into some graphs. So this is kind of the quintessential randomized control trial situation where we have a kind of pure treatment mean, a pure control mean, no spillovers here. And what we just need to do is we've randomized, we're going to compare treatment to control, and we get this kind of unbiased estimate of the kind of direct treatment effect. And we kind of think about this as kind of a bar chart where kind of a taller bar is kind of a better outcome. So that's kind of the effect that we want to get and that the RCTs are kind of designed to capture. But when we have spillovers, what ends up happening is we end up seeing this kind of middle bar. So we look at the control group and we see that their overall effect is a combination of their pure control effect plus these indirect benefits. So again, the kind of indirect spillover benefits of indirect protection from vaccinations. And so we're getting this biased effect from that indirect benefit. So we end up, when we're comparing the pure treatment effect to this kind of combination bar in the middle, then we're going to get we're kind of estimating a smaller effect than the true effect. So we're going to say, oh, well, this didn't look like it was very effective. Maybe it wasn't statistically significantly, different from the control. Maybe it doesn't look very cost effective because even if there was a benefit, it wasn't, it's just too expensive for the benefit. So we're going to end up being wrong. So kind of why do we care about spillovers? Well, if we care about being right, making kind of drawing the right conclusions from our RCTs and making the right kind of guideline and policy decisions, subsequently, we want to make sure that we're right, and these spillovers are going to lead to bias. And as an aside, which I'm not going to get into today, but the treatment group also gets some indirect benefit. When you get vaccinated as part of the treatment group, you're also benefiting from indirect protection from other people in the treatment group. So if the vaccine does not offer kind of sterilizing protection, if there's only kind of partial protection, then you, even though you're vaccinated, you get a direct protection, but you also get indirect protection from others. So that's kind of a component that's often that's not necessarily always considered, but that's kind of worth considering as well. That when there's spillovers, they spill over to the control group, but they also spill over within the treatment group. So it could be that you're actually seeing that. And so the best practice study that I'll talk about today, actually their method will capture that because they're measuring all of the direct effects and all of the indirect effects for everybody. So that's kind of a key thing to remember is that these spillovers are not just from treatment to control, it's from treated people to other treated people and can give kind of an additional layer of protection, for example, with vaccines. Okay, so how do we address this in trial design? So one of the key things about externalities is that we cannot eliminate externalities from happening. They are going to happen. We can potentially minimize the impact on our study, but we can never completely eliminate them. And I think about this as very similar to dealing with issues of attrition or non-compliance with the treatment assignment, is that we cannot compel people to not drop out of our studies because of research ethics, and good luck trying to do that. And we can also not compel people to follow the treatment assignment. So what we try to do is design the studies to kind of minimize attrition and to minimize non-compliance as much as possible. And then when we know that that happens, we want to make sure that our statistical analysis is going to kind of take those things into account and try to kind of get the correct answer despite any non-compliance or attrition. So it's a kind of similar approach with externalities that the main thing is that we want to try to minimize them, but the key is if we kind of measure them and then adjust our analysis, then we can kind of capture the effects of the externalities and address any bias. And so we often actually don't want to prevent spillovers. So part of it when we're looking kind of from a clinical perspective is that often the key thing that we're looking for is the direct effect. We're maybe not that interested in the indirect effect because it's just not part of kind of what the decision is, not included as much in the decision-making process, or we're potentially not powered to capture the indirect effect. So it's really kind of a secondary consideration. But when we think about things like indirect protection from vaccines, from vaccination, we want those spillovers. And those spillover benefits, indirect benefits, are technically part of the overall benefit of vaccination. And so, in my view, as much as possible, it makes sense to try to include these indirect benefits. I'll talk a little bit more about that towards the end of the talk. But when we're thinking about things like cost effectiveness and making kind of policy decisions, these spillovers are kind of a key component of the policy decision. If you have a vaccination that isn't extremely effective in terms of direct protection, but somehow kind of adds up and provides a lot of indirect protection, then that's something that would be kind of very worthwhile as a policy. And kind of one example of this is the influenza vaccine, which is often kind of not, it's not sterilizing immunity, and the effectiveness kind of changes year to year, but it provides a lot of indirect protection to children and to the elderly. And so those spillover benefits can really make it worthwhile, even though it doesn't offer a lot of direct protection and to people who are kind of um, in between being a child and being elderly. It still is kind of part of the overall big picture of, is this the kind of vaccine that we want to provide to the population? So in my view, kind of it's good to keep that in mind, that it can actually really benefit the kind of overall big picture, to keep spillovers in mind. So generally, the approach is not necessarily to try to prevent externalities or spillovers. It's really that we want to kind of measure them in order to be able to separate them from the direct effects. We can estimate the direct effect and the indirect effect, and consider those two. So the key is that spillovers aren't a problem as long as it's part of your model and estimation. That said, including it as part of your model and research design and part of your estimation is not always that easy, and some of it is because it requires often a much bigger sample size to really do that, and that costs money. So I'm not suggesting that that's necessarily easy to implement, but the kind of approach is pretty straightforward. I guess I'll just pause here. Are there any clarifying questions about anything that I've brought up so far? Okay.
I think it's all good, Zoe. Go on.
Say that one more time.
All good. Go on.
Okay, great. I'll carry on. Thank you. Okay. So there's two main strategies for addressing spillovers in trial design. So the first thing is to try to minimize spillovers. So if you think about how we try to minimize non-compliance in trials, one approach is that we have kind of separate clinics, and each clinic either only does the treatment group or only has the control group. So it leaves a little bit less leeway with clinicians and people to kind of know that there's two different groups, or to swap back and forth. So kind of a similar idea with the spillovers is that instead of randomizing at the individual level, we randomize clusters. And so these clusters could be kind of clinics, could be school classrooms, entire schools, particular communities. And the idea is that the clusters are going to be separated in time and space, so that they're kind of less likely to interact with each other, so that they are the people that are in kind of a treated cluster are less likely to interact with the control clusters, and therefore less likely to kind of provide that indirect benefit or indirect cost to them. So we're going to be randomizing at the cluster level. So when we think about statistical power, randomizing at the cluster level means we're going to need a bigger sample size, because we're going to need kind of more clusters, and more clusters that are somewhat separate in space from each other. So clustering, so providing the treatment at the cluster level rather than the individual level is kind of the first strategy. And the second strategy is to kind of say, okay, we're not going to try to prevent the spillovers, but we're going to randomize the amount of spillovers that everybody is exposed to, and then we're going to measure the effect of that. So the idea is that we kind of assign these clusters to a dose of a spillover. I'll talk a little bit about how that's done, but the idea is kind of within the cluster that you're going to be treating, either no one in the cluster, or 20% of the people, or 50% of the people, or 100% of the people in the cluster. So each cluster gets randomized to kind of a proportion treated. So it's kind of a dose of the indirect exposure. And then based on that randomization, then we'll look at what is the impact of an extra 10 percentage point increase in the proportion treated on these outcomes to be able to capture that kind of dose response curve of the spillover. So again, it means that we want to randomize the amount of spillover because as we know, if we don't randomize it, then we don't necessarily get an unbiased effect. If we just say, let's let's offer the treatment and see who takes it up and then use that number, that's not going to give you an unbiased effect because you're not randomizing the amount of the spillover. So you need to be able to randomize it and then measure it. Okay. So I want to talk just a little bit about one example. This is the Miguel and Kramer worms paper from 2004 that you may have heard of. There was like a little bit of or maybe a lot of a debate between economists and epidemiologists about this paper, but it is kind of considered the seminal best practices paper in this field. So it's the paper's called Worms: Identifying Impacts on Education and Health in the Presence of Treatment Externalities. So that externality word is our economist word for spillovers. And so I was a study performed in the Busia district of Western Kenya, and they were looking at the kind of hookworm, roundworm, whipworm, and schistosomiasis, and they were providing deworming drugs to school children and wanted to look at the impact on school absenteeism and performance and kind of capturing the impact on the worm burden as the pathway to these effects on education. And so humans play a role in the transmission of these worms. So kind of being around other people who are infected by the worms is going to increase your likelihood of contracting them and increase the worm burden in your digestive system. And so there are these kind of large spillover effects because it's quite kind of the pathogen passes through humans. And so before they did this study, there were several, many studies that looked at kind of the impacts of deworming, but these studies did not account for spillover. And so so if you have this positive benefit of deworming, right, you deworm yourself, it's going to help protect people around you. If you have a positive benefit, then does that mean we overstate or understate if we don't take that into account? It means they're going to be understating. So the previous studies would have found that there was a kind of much smaller than the true effect because they weren't capturing the spillover effect. So they went in and they used their study was 75 schools in Western Kenya, about 30,000 students. It was a massive, massive study. Again, trying to randomize the amount of spillover and capturing all of that often takes a lot more resources. And they randomized at the entire school levels. So these are kind of middle, elementary school, middle school, I think students all the way up to 18. So they randomized each school to being a treatment school or a control school. The treatment schools, everyone was offered the deworming. The control schools, no one was offered the deworming until several years later. They had this kind of delayed due to the kind of research ethics, right? They didn't want to deny anyone the deworming treatment that was known to be effective. And so it was offered kind of subsequently after the study. And then they were able to estimate this direct effect of the deworming on the individual schools, for people actually taking the deworming drugs themselves, as well as the spillovers from those who took the deworming drugs to people who hadn't taken, who weren't part of the treatment group. And they're able to kind of estimate that across these different schools. And what they did is they were able to quantify the kind of dose of spillover effect by looking at each of the schools and figuring out within a radius how many treated kids were at schools within the radius, either like 3 kilometers or 6 kilometers. So they were kind of, it was this massive study and kind of looking at within your community, kind of measuring the spillover. And because they randomized for each of the schools, the number of kids in that radius was also randomized. The dose of the spillover was randomized. And so here on the left would be the kind of typical kind of pre-Miguel and Kramer, not thinking about spillovers design. You'd have all of these little dots the circles would be a school, and you do like 50% treated and 50% control, and then you'd compare the treated kids to the control kids and get your estimate, right? Very straightforward, but in this case, very wrong answer. And so on the right, what Miguel and Kramer did is for each of the schools, the entire school was treated or the entire school was control. And they randomized each of the schools to being either treated or control. And then what they did is they wanted to measure the spillover exposure. So they would take a school, in this case we have a control school in the middle of that red radius, and they would say, well, how many treated schools are in that area? And so you have kind of three schools that are half or more in that radius, and so they would assign that a kind of a value of three. They did this by actual numbers of students, but just to kind of give you an idea. So the look at the kind of the proportion of the number of treated schools. Again, another control school. It had two treated schools within a radius. It would be kind of given an exposure dose of two, and you do the same thing for the treated schools. So this treated school had one, I guess it was right on the border there, but one treated school within that radius. So it was kind of considered that it was getting kind of a dose of one of this indirect protection from the treatment. So again, the treated schools also get the indirect protection. They get the deworming that's going to basically wipe out the worm population in their digestive system. But by being exposed to other treated kids, those kids are also, since they've been dewormed, are less likely to transmit worms to them. So their worm burden is going to kind of come back up to the previous level much more slowly. So again, these indirect effects, it's not just the treatment group that gets it. It's not just the control group that gets it. The treatment group is also getting the indirect effects. So kind of best practices is measuring the indirect effects both for the control group and the treated group, and then disentangling the direct effect from the treated effect. So I'll skip over showing you all of their detailed results. They're all on the paper, which is accessible, and I can send it to you if you'd like to see it. But they were able to find that deworming reduced absenteeism from about a 20% absenteeism rate down to a 15% absenteeism rate, which is a pretty big change. Hard to get kids to stop being absent from school. And they found that the intervention, because these deworming is so inexpensive, that it was very cost effective as both a health intervention and also as an education intervention. A lot of the education interventions involving like school uniforms and books and better teachers are pretty expensive, and this was actually getting a much bigger bang for your buck in terms of the education benefits. So kind of health policy is really education policy. And we often think with these indirect effects that, oh, the direct effect is going to be the biggest and the indirect effect is going to be kind of smaller, maybe negligible, maybe close to zero. But in this case, the kind of overall health effect, which they measured, the externality, this indirect effect was 75% of the total effect. So the indirect effect was three times bigger than the direct effect. And that's often the case with infectious disease and pathogens that are transmitted, because when you think about it, everybody around you is giving you protection. So you're kind of getting like the indirect effect really adds up because everyone's getting it. Everyone's getting a lot of indirect from all the people around them. So it's just kind of a reminder that this is why it's really important to always consider spillovers, because they're often bigger than the direct effect. And again, if you don't account for them, it could totally end up kind of washing out the full effect of the treatment that you're looking at. But it's something where I want to coin this as like the McClaren rule. But if something is hard to measure, people just assume it's zero. They make this kind of implicit assumption that it's zero, like we're not going to worry about it. If someone else has coined that rule, please let me know. But I've found that when things are hard to measure, people kind of just forget about them and assume they're zero. But here with spillovers, that's the kind of a huge impact. And when we're thinking about making decisions about guidelines, decisions about policy, we're often like, oh, do we want to implement this, this new drug, this new vaccine, this new treatment? Oh, it's like so expensive. I don't know if it's going to be worth it. Well, if we're taking into account the externality, all of a sudden that could totally change the tune about whether something is cost effective or not. So I always like thinking big picture about externalities, because oftentimes it really changes the answer where it's like, ah, that looks really expensive. I don't know if it's worthwhile. But hey, actually, when we take the bigger picture, we see it is worthwhile. And I think that that point is really relevant for all of the work that you're doing on antimicrobial resistance. And we think about like the potential costs of losing, losing some of these antibiotics we rely on. Those are really big kind of externalities of the behavior, the kind of the clinical practice we have right now. And so taking those into account is going to make the work that you do seem kind of even more valuable than everyone already thinks it is. Okay. So putting this into practice, what do you want to do with all this information that you've just gotten today? So the first thing is if you are designing clinical trials, you want to think about the spillovers. Are you able to do kind of the best practices in terms of capturing the spillovers? And if not, then there's maybe a way to put that into limitations or to kind of think about couching your results in that. Some of it is if you're not able to capture the spillovers, but you're sure that pretty sure the spillovers are going to be kind of benefits, you could say, well, we found a benefit of this treatment, but we weren't able to capture the spillovers, which are going to probably make it look even more beneficial. So we have a lower bound on, how effective this treatment is or how beneficial this treatment is. So kind of doing what we can in terms of clinical trials to kind of do that, randomizing the spillovers, minimizing the spillovers or randomizing the spillovers and measuring them. The second is when you're reading other studies. There are a lot of studies in the very top journals that don't adequately address spillovers or don't consider spillovers at all. And so that is something that you want to kind of take into account when you're reading a study is thinking, okay, well, what are the spillovers that could have occurred here? And how are they likely to affect the kind of estimates? Again, if we know the spillovers are positive, then not taking them into account is going to understate the benefits of the treatment. If we know the spillovers are likely to be negative, then that means they're going to be overstating. So we are able to kind of determine whether the bias is kind of positive or negative, and that means we can still kind of interpret, kind of think about how to interpret the studies if they haven't considered spillovers. And again, this also applies to kind of studies from 20 or more years ago, if those are still relevant, that was kind of less part of the discussion, perhaps, and so kind of a way to think about those results. The third point is to kind of think about for cost effectiveness estimates. So if you are in your study doing anything to discuss any of the cost effectiveness of the treatment, even if you're not fully able to capture the spillovers in your study, you can still include that as part of the cost effectiveness kind of analysis as part of the limitations. Basically saying again, like, oh, this is, just barely cost effective, but we didn't take into account the spillovers, which are these additional benefits that would make it look much, much more cost effective than it actually is. And so when I'm thinking about cost effectiveness, I always want to think about kind of all of the benefits and costs as much as possible, to kind of make sure that you're actually capturing the true cost effectiveness from the big picture. And then the last point here is that, um, with spillovers, again, that point I made early on about the fact that spillovers occur when there's these external actors who they don't have a seat at the decision-making table. And so their their kind of benefits or costs are not taken into account. Oftentimes, this kind of higher level authority is saying, "Oh, well, actually, we do want to make sure our clinicians are taking into account the other patients in the hospital or the future patients." Right? That's what we think about with antimicrobial resistance: is we want these drugs to be available in 5 years for patients then. And so what we need to do is kind of we think about it as some way as giving those people a seat at the table. Like let's take into account what would be beneficial for them as well. And then let's design some guideline or some policy that's going to um, kind of encourage or require in some way the actors to act as if those external actors had a seat at the table, right? So clinicians are not always thinking when they have a patient in front of them about the other patients in the future. But when you have guidelines about how you use antibiotics, for example, you're kind of compelling people in some way to kind of think, okay, well, I want to kind of weigh the benefits and costs in this certain way. So that's kind of this guidelines or policy that we have these externalities that lead to these suboptimal outcomes when we just let people, kind of when we ignore the external actors in the decision, we get these suboptimal outcomes. But if we think about big picture, what the optimal would be, then we can have guidelines or some kind of policy that might not necessarily get us directly to the optimal point, but that will get us closer to that. And so when I'm thinking about the work that I'm doing, I'm often um, thinking about kind of how to capture these spillovers and how to think about guidelines or policy. Okay. And so the key thing here is with clinicians that you do have this fiduciary duty to focus on the patient right in front of you. And so sometimes it is a requirement that you need the guidelines that to help you think about people beyond that patient in order to balance those two. So I think that's something for you to kind of think about here. And I'd be really interested to hear kind of your perspectives on that. Okay, so just very quickly, some of the examples from my work. So I've done work on rapid antigen testing for COVID. Primarily, we think about the kind of direct benefits about you learn whether you're infectious, you can access treatments. Early on, when there really weren't treatments available, people had argued, well, we can't treat them. What's the point of doing any testing or subsidizing testing? But we get these spillover benefits in terms when people test and they realize that they are infectious, they're more likely to stay home, they're more likely to mask up. And so a lot of the benefits of the testing was actually in these spillover benefits. So the kind of, optimal policy would be to subsidize them, to encourage people to test, even if they weren't getting a lot of direct benefits, because it would have provided these indirect benefits to other people. And I have a set of studies that look at ART and finding that we know that there's kind of direct benefits of getting access to ART on people who are getting on the treatment. But I was actually able to find that there are benefits to people who are not infected with HIV and who don't have anyone in their household who's on ART either. So, kind of, why are they getting these benefits? And basically, the pathway seems to be that when ART becomes available, it changes everyone's future. They know if they are HIV infected that they'll be healthier in the future. If they are not infected, that even if they do, they can still be healthier in the future, and that everyone around them is going to be healthier. So people are more likely to invest in education, invest in job search, and businesses are more likely to hire people because they're less likely to kind of get sick and have more employee turnover. So again, kind of ART actually benefits everyone in the community, even people who are not infected with HIV or who don't have anyone in their household who is on ART. So again, health policy is economic policy. We want to think about kind of bigger picture when we're considering cost effectiveness. Okay. And with that,